Hi, I'm Kim Blackwell from Duke University Medical Center and the Duke Cancer Institute in Durham, North Carolina. I want to welcome you to this educational activity on HER2-positive breast cancer.
The following audio is from a two-part video presentation with Dr. Kimberly L. Blackwell. This audio is part of a certified educational activity titled Raising the Bar in HER2-Positive Breast Cancer, Improving Patient Outcomes in the Neoadjuvant Setting. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/QSA. A printable transcript, slides, practice aids, and other features are also available.
Historically, HER2-positive breast cancers were considered to be the most aggressive female cancers due to the hyperactivation of HER2 and its signaling systems in breast cancer cells. However, with the recent advent of HER2-directed therapies, this breast cancer subtype has become highly treatable in both the neoadjuvant and adjuvant clinical settings. The first clinical trial that combined Trastuzumab with chemotherapy showed significantly improved overall survival in patients facing metastatic HER2-positive breast cancers. Likewise, administering Trastuzumab to patients with early stage and locally advanced HER2-positive breast cancers demonstrated similar survival benefits, therefore revolutionizing the management of this type of breast cancer in both the adjuvant and the neoadjuvant settings. Because of the proven successes of Trastuzumab, in other words, it was shown to improve survival in the metastatic and adjuvant setting, we've now discovered many other novel ways to target the HER2 family. Let's discuss neoadjuvant therapy for HER2-positive breast cancer and where the current evidence is. Well, the rationale for giving neoadjuvant treatment or treatment before surgery includes many clinical benefits. These include downstaging or shrinking the tumor in the locally advanced or the inflammatory breast cancer setting, turning an inoperable tumor into an operable tumor, converting someone who would need a mastectomy to breast conservation. And finally, for patients who have large axillary lymph node involvement, there's a decreased likelihood of having positive lymph nodes remaining. Now, the neoadjuvant setting also offers many research or drug development benefits, and these include really an in vivo assessment of whether or not the treatment is working or not. A response to neoadjuvant therapy provides important prognostic information, and really more on a societal basis, the neoadjuvant setting allows us to study promising tumor biomarkers and really quick turnaround endpoints for drug development. So Trastuzumab, our old friend, is a HER2 receptor antibody or antagonist, and it is indicated for the adjuvant treatment of HER2 overexpressing node-positive or node-negative breast cancer. It should be included as part of a treatment regimen consisting of doxorubicin, cyclophosphamide, and either paclitaxel or docetaxel, or a non-anthracycline regimen such as docetaxel carboplatin, or it can be used as a single agent following anthracycline-based therapy. In the metastatic setting, Trastuzumab is used in combination with paclitaxel, or is indicated in combination with paclitaxel for the first-line treatment of HER2 overexpressing metastatic breast cancer, or as a single agent for the treatment of HER2 overexpressing breast cancer in patients who have received one or more chemotherapy regimens for metastatic disease. We already discussed the clinical and research benefits of using Trastuzumab in the neoadjuvant setting, and now we're going to examine the endpoints of pathologic complete response across a portfolio of neoadjuvant trials that have been performed. So the MD Anderson study, when Trastuzumab was added to an anthracycline taxane regimen, the complete pathologic response rate was 65.2%, compared to 26% in patients who did not receive neoadjuvant Trastuzumab. This was a very important early study because it really demonstrated the benefits of adding Trastuzumab in the neoadjuvant setting. Likewise, the NOAA study looked at Trastuzumab with chemo or chemotherapy alone. And as you can see, the complete pathologic response rate was 43% in those women that received Trastuzumab, compared to 22% in those women who did not, highly statistically significant. And then finally, the German cooperative group in a study known as GPAR-Quattro looked at Trastuzumab in combination with chemotherapy in the neoadjuvant setting. And what you can see is that the pathologic complete response rate, meaning no tumor left, was somewhere between 31.3% and 34.6%, really demonstrating that if you incorporate Trastuzumab in the neoadjuvant setting, 1 out of 3 women just in general will have no invasive disease left at the completion of their neoadjuvant therapy. So these are the 3 studies that historically set a standard for not only utilizing Trastuzumab in the preoperative setting on top of a chemotherapy backbone, but also being able to establish a marker of efficacy, in this case, a complete pathologic response. In 2014, Luca Gianni, on behalf of his colleagues, reported the updated results from the primary analysis of the NOAA, this is the neoadjuvant Trastuzumab study, and really examined the long-term benefits of adding Trastuzumab to neoadjuvant chemotherapy. After a median follow-up of 5.4 years, the event-free survival benefit from the addition of Trastuzumab to chemotherapy was maintained in patients with HER2-positive breast cancer. For those patients who only received chemotherapy, the event-free survival was only 43% at 5 years, compared to a 58% 5-year event-free survival in the patients who received both chemotherapy and Trastuzumab. More importantly, and as a demonstration of the importance of the neoadjuvant platform, event-free survival strongly was associated with a complete pathologic response in those patients who received Trastuzumab. At the time of this final analysis from 2014, fewer patients had died in the Trastuzumab group than in the chemotherapy alone group. And as we're all interested, the majority of the deaths came from breast cancer progression and recurrence. So at this point, I've kind of gone over the neoadjuvant Trastuzumab, at least in combination with chemotherapy, has a demonstrated benefit in the neoadjuvant setting, and really set the stage for newer drugs that target HER2. One of these drugs is known as Pertuzumab, and Pertuzumab is very similar to Trastuzumab in that it's a recombinant humanized monoclonal antibody directed at the extracellular domain of HER2. Its main mechanism of action is it prevents dimerization of HER2 with other family members such as HER3 and HER1. By blocking this heterodimerization, this results in inhibited downstream signaling of 2 pathways, primarily apoptosis and growth or proliferation. In addition, this antibody, Pertuzumab, very similar to Trastuzumab, has been demonstrated to augment antibody-dependent cellular-mediated cytotoxicity. So Pertuzumab, just like its predecessor Trastuzumab, has been studied in the neoadjuvant setting, and we can utilize a complete pathologic response rate to determine whether or not it's effective in this setting. So there are 2 large studies. The first study is known as the Neosphere study, and again, Luca Gianni led the way with this neoadjuvant study. This is a 4-arm study, and the highest complete pathologic response was when Pertuzumab was given in combination with Trastuzumab and docetaxel. The complete pathologic response rate in this winning arm of the Neosphere study was 45.8%. And somewhat disappointingly, the pathologic complete response to the 2 antibody combination of Pertuzumab and Trastuzumab led to the lowest rates of complete pathologic response, 16.8% in the breast alone, and 11.2% if you look at clearance of both the breast and the axilla. And so the Neosphere study really demonstrated that you could layer on Pertuzumab on top of Trastuzumab and docetaxel and get a higher complete pathologic response compared to the docetaxel and Trastuzumab, or the historical control arm. Now at ASCO in 2015, Dr. Gianni looked at the long-term results of Neosphere. Now, it's important to recognize that the primary endpoint of Neosphere was the pathologic complete response, but this was always a planned analysis. And what this outcomes analysis showed was that the combination of Pertuzumab, Trastuzumab plus docetaxel had the best long-term outcomes. And although the point estimates are consistent with the relationship with the pathologic complete response, there was no statistically significant difference between the 4 arms of the study. However, when you examine the estrogen receptor negative patients, there appeared to be an even larger improvement in outcome as it correlated with their upfront pathologic complete response. So I think what Neosphere really set the standard was the addition of Pertuzumab to standard chemotherapy and Trastuzumab-based neoadjuvant therapy. But it also set a new standard that if we see a higher complete pathologic response in the neoadjuvant setting, that translates to improvement in outcome. And finally, we did not see any safety signal with the addition of Pertuzumab to standard chemotherapy and Trastuzumab. And really, Neosphere set the standard for one of the reasons why Pertuzumab is currently available in this setting. Now, the second neoadjuvant study looking at the addition of Pertuzumab or the use of Pertuzumab is known as Tryphena. Now, this was a multi-center phase 2 study looking at early-stage breast cancer or locally advanced or inflammatory breast cancer. And the primary purpose of the Tryphena study was really to look at the feasibility or the tolerability of Pertuzumab chemotherapy combinations in the neoadjuvant setting. And as you can see, the complete pathologic response rate in the Tryphena study was quite high in all 3 arms. The highest arm for complete pathologic response was the docetaxel carboplatin, Trastuzumab, and Pertuzumab arm, giving us a pathologic complete response of 66.2%, compared to 61.6% and 57.3% complete pathologic response rates with the anthracycline-containing regimens. So, my take on the Tryphena study is that close to 2 out of 3 patients had a complete pathologic response rate when Pertuzumab was added to Trastuzumab. And if you remember just a few minutes ago, we said about 1 out of 3 patients achieved a complete pathologic response with the addition of Trastuzumab. Therefore, these 2 studies, both the Neosphere study and the Tryphena study, really demonstrated a significant improvement in complete pathologic response rate when Pertuzumab was added to the regimens. One of the primary endpoints of Tryphena was to look at cardiac safety, and somewhat reassuringly, the cardiac events in the Tryphena study, even when the Pertuzumab and Trastuzumab were given concurrent with the anthracycline, were quite low. There was only 2 patients who actually developed grade 3 or 4 left ventricular systolic dysfunction, and that was actually when the HER2 targeted agents were not given concurrent with the anthracycline, really suggesting that the addition of Pertuzumab to Trastuzumab and chemotherapy does not add anything to the signal. So how is Pertuzumab actually approved throughout the United States? Well, it's approved as neoadjuvant treatment for HER2-positive breast cancer, and its indication is in use in combination with Trastuzumab and docetaxel in the neoadjuvant setting for patients who have early stage or locally advanced or inflammatory breast cancer. I should point out that Trastuzumab and Pertuzumab are not interchangeable and that the indication really is to add Pertuzumab to Trastuzumab. Pertuzumab by itself really hasn't been approved outside of in combination with Trastuzumab. Many of us use guidelines in considering regimens for our patients, including the National Comprehensive Cancer Network or the NCCN guidelines. The NCCN guidelines basically recommend the addition of Pertuzumab to neoadjuvant or adjuvant therapy for patients with early-stage breast cancer. And in fact, in the guidelines, it's stated that a Pertuzumab-containing regimen may be administered preoperatively to patients with either a greater than T2, meaning greater than 2 centimeter tumor, or node-positive, HER2-positive breast cancer. What should we expect over the next couple of years as far as helping us understand even further the role of Pertuzumab in the treatment of early-stage breast cancer? Well, I think there are 2 important studies. So the Berenice study is a multi-center, open-labeled phase 2 study to evaluate the safety and efficacy of Pertuzumab in combination with Trastuzumab and anthracycline-based chemo as part of neoadjuvant therapy in women facing HER2-positive, locally advanced inflammatory or early-stage breast cancer. I think that this is an important study because it really gives us the information we got from Tryphena for Pertuzumab, but really in a more practical way, which is most of us, when we utilize an anthracycline, we use it in a sequential fashion. So it's kind of a complicated schema, but the net is it's a 2-arm study really looking at the feasibility of an anthracycline-based regimen followed by a taxane, Pertuzumab, and Trastuzumab. The primary outcomes of the Berenice study include cardiac events as assessed by the investigator and also long-term follow-up, including patients go on to get Pertuzumab and Trastuzumab. Now, the second study that I think is also going to be useful is the Christine study. And this was a randomized, multi-center, open-label, 2-arm study comparing a newer agent, TDM1 plus Pertuzumab, to what has already been firmly established, chemotherapy, Trastuzumab, and Pertuzumab in the treatment of early-stage HER2-positive breast cancer. Like all of the neoadjuvant studies we've discussed today, one of the primary outcome measures is a complete pathologic response rate with long-term outcomes to include event-free survival and overall survival, as well as conversion or the rate of breast conservation therapy, given that it was a preoperative therapy. So Christine's important because it will really help us understand not only the role of docetaxel, carboplatin, Trastuzumab, and Pertuzumab, which is my standard neoadjuvant regimen currently, and comparing that with a TDM1 Pertuzumab regimen, which really does have some potential benefits, including the absence of hair loss.
Results presented at ASCO 2016 showed that while treatment with TDM1 plus Pertuzumab led to a pathologic complete response in 44.4% of women, docetaxel carboplatin with Trastuzumab and Pertuzumab yielded a significantly higher pathologic complete response rate. However, TDM1 plus Pertuzumab had a notably better safety profile, and health-related quality of life and physical functioning were maintained longer.
Now, TDM1 is the first antibody-drug conjugate approved for the treatment of any solid tumor in the United States and really throughout the world at this point. And it is a combination of our old friend Trastuzumab linked to a cytotoxin, in this case, DM1 or derivative of maytansine. So really, I do tend to think of these ADCs just like carrier pigeons. They get in, they release their drug. And what's interesting about the ADCs is that, at least in the case of TDM1, you still maintain free Trastuzumab levels like you would if you were giving it outside of the antibody-drug conjugate. Obviously, delivering chemo or cytotoxics only to the cancer cells that have HER2 on their surface means that you're only delivering chemotherapy to the cancer cells themselves. And so what we see, even though it is chemotherapy, it's chemotherapy bound to Trastuzumab, and therefore we see a very tolerable safety profile. We can see a mild to moderate elevation in liver enzymes that occurs in somewhere between 5 to 10% of patients, and you can see a mild to moderate, meaning grade 2 to 3 thrombocytopenia in patients receiving TDM1. But other than that, there's really less than 1% incidence of nausea and vomiting, and probably most important for patients facing early stage breast cancer, there's no hair loss associated with TDM1. The first study that fueled some enthusiasm about the use of TDM1 in the preoperative or neoadjuvant setting is a study known as ADAPT. This is a large German-based study. It is considered an umbrella study in that it has different phenotypes, but what we're going to look at today is really the HER2-positive arm of the ADAPT study. So what's interesting about the HER2 component of the ADAPT study is that none of these patients got standard chemotherapy. 2/3 of them got TDM1, and 2/3 of them got endocrine therapy, either in combination with the TDM1 or in combination with our old friend Trastuzumab. And so this is really, I think, a revolutionary study because we're basically taking early stage breast cancer patients and treating them in the preoperative setting with non-traditionally chemotherapy-based regimens. So what did the ADAPT show us in terms of complete pathologic response rates? In the TDM1 monotherapy arm, the complete pathologic response rate was 41.0%. And when endocrine therapy was layered on top of the TDM1, the complete pathologic response rate was 41.5%, really suggesting that adding endocrine therapy on top of HER2-based therapies does not achieve a lot more in terms of a complete pathologic response. And even more surprising is how ineffective the combination of trastuzumab and endocrine therapy were in the third arm of the study, where a complete pathologic response rate was only 15.1%. So I think, my conclusions about the ADAPT study was really that TDM1 as a single agent led to very high complete pathologic response rates, that adding endocrine therapy on top of HER2-targeted agents really doesn't add much. And I think we're anxiously awaiting the long-term and secondary outcomes of this study to include event-free survival and overall survival, which I would imagine would come somewhere in the next 3 to 5 years. We also got some very interesting data about TDM1 from the AACR meeting in 2016. Now, TDM1 had been included in a preoperative, really kind of a novel drug development trial known as the I-SPY2 study. It confirmed the data that we saw in the ADAPT study, meaning when TDM1 was added in the neoadjuvant setting, the complete pathologic response rate was actually 52% in patients who had gotten TDM1 and Pertuzumab, compared to 22% in patients who got the standard combination of paclitaxel trastuzumab. This was really important because it compared our old combination of paclitaxel trastuzumab to TDM1 and Pertuzumab. And because of the very high complete pathologic response rate, the study investigators concluded that the probability of TDM1 Pertuzumab wasn't just probable, it was superior to paclitaxel trastuzumab with a pretest probability of about 99.5%. And that would predict success of the TDM1 Pertuzumab combination and subsequent neoadjuvant studies at close to 94%. Again, very similar to what we saw with ADAPT, very few grade 3 or 4 adverse events in either arm of the study. There was increased rates of hypertension, neuropathy, and alopecia in the women who were receiving standard paclitaxel trastuzumab. The alopecia almost certainly from the paclitaxel, and the hypertension almost certainly from the steroids that are required with paclitaxel. In the TDM1 and Pertuzumab arm of the I-SPY2 trial, we did see an elevation in the liver enzymes, which are known to occur with TDM1. But the liver enzyme elevations were low grade and were not clinically significant. So now 2 studies really looking at the activity of TDM1 in the preoperative setting, suggesting that it will play a role moving forward. Not yet indicated or approved in the United States, but with the kind of efficacy data that we're seeing, very exciting and certainly warrants further studies of the use of TDM1, either in combination with Pertuzumab or in combination with other agents. And finally, we're going to discuss Lapatinib. Now, Lapatinib in the neoadjuvant study has been studied in a series of studies. Lapatinib is a small molecule inhibitor that actively competes intracellularly with ATP to block downstream signaling. And so the fact that it has a different mechanism of action made it a very attractive drug over the past decade to combine with trastuzumab to see if basically combining 2 different mechanisms of action against HER2 would lead to greater efficacy. Now, the large study that looked at the role of Lapatinib in the neoadjuvant setting is known as NeoALTTO. The study schema was quite simple: Lapatinib in one arm, IV trastuzumab in another arm, or the combination of Lapatinib and trastuzumab for a period of 6 weeks, and a biopsy was done at enrollment and after the 6 weeks. Then women went on to receive 12 weeks of the targeted agents plus paclitaxel. What did we see? The PCR rate was significantly higher when Lapatinib and trastuzumab were added to paclitaxel than either trastuzumab alone or Lapatinib alone. There was no difference between the Lapatinib arm and the trastuzumab arm. So clearly, Lapatinib, trastuzumab, and paclitaxel led to a near doubling in the complete pathologic response compared to either trastuzumab paclitaxel or Lapatinib paclitaxel. And there was no major episodes of cardiac dysfunction. We've seen a number of analyses looking at how PCR correlates with long-term outcome in the NeoALTTO study. And basically, even though each of the arms was studied independent in the NeoALTTO study, those women who have a complete pathologic response always tend to have a significantly longer event-free survival and overall survival. The importance of NeoALTTO, even though Lapatinib is probably not going to be approved in the neoadjuvant setting, is it's yet another study that really says if you achieve a complete pathologic response with whatever agents, it does correlate quite nicely with long-term outcome, either event-free survival or overall survival. The NeoALTTO study was partnered with a sister trial known as ALTO, and this is a traditional adjuvant study looking at either Lapatinib for a year, Trastuzumab for a year, Trastuzumab followed by Lapatinib, or the doublet that we just examined from NeoALTTO, which is Trastuzumab combined with Lapatinib. Now, one thing that was known very early on, about 2.5 years into the ALTO having completed accrual, was that the patients who got chemotherapy plus Lapatinib alone, the one arm that did not receive Trastuzumab, the patients did not do well in that arm, and so the DSMB actually shut down that arm and offered patients Trastuzumab. So the initial study results were released with about 4.5 years of follow-up. Although there was a trend to an improved event-free survival in favor of the combination of Lapatinib and Trastuzumab compared to Trastuzumab alone, it did not reach statistical significance. The p-value was 0.048, and because of the multiple arms of the study, the predefined statistically significant value had to be less than 0.025. So basically, there was no statistically significant benefit for the addition of Lapatinib to Trastuzumab, and there was certainly no difference between the sequential use of Lapatinib and Trastuzumab and the doublet. So short of another confirmatory study that reaches statistically significant endpoints, it's unlikely that Lapatinib will become a standard of care in the neoadjuvant or adjuvant setting. What I really want to end this discussion with is really what are the practical recommendations for managing patients with HER2-positive breast cancer in the neoadjuvant setting. The current NCCN guidelines list the following preferred regimens: AC followed by paclitaxel, trastuzumab, and pertuzumab, docetaxel, carboplatin, trastuzumab plus pertuzumab, and they also list other regimens including AC followed by docetaxel, trastuzumab, and pertuzumab, FEC followed by docetaxel, trastuzumab, and pertuzumab, and then finally weekly paclitaxel and trastuzumab. The NCCN guidelines also suggest that we shouldn't utilize anthracyclines with HER2-targeted agents given the increased risk of cardiac toxicity. Now, one of the most practical aspects of utilizing preoperative or neoadjuvant HER2-targeted agents is just getting all of the doctors on the patient's care team on the same playing field. And it does require a fair amount of collaboration for treatment planning. Neoadjuvant therapy has, in the old days, and I mean like over 10 years ago, was really reserved for locally advanced or inoperable breast cancer. And at least in my opinion, it is now the standard of care for patients facing HER2-positive earlier stage breast cancer. Not just confined to locally advanced, but really when you know a patient needs chemotherapy and HER2-targeted therapy, there's really not a downside to offering it in the preoperative setting. In addition, there are a number of clinical trials and correlative tissue studies that will help us understand the effects of HER2-targeted agents. And really, the patients participating in the trials and the patients that come after them will all benefit from the opportunity to use neoadjuvant therapy in order to get us to where we all want to be, which is personalized or precision medicine. We still have a lot to learn about the use of neoadjuvant therapy, duration of therapy, Do we continue the Pertuzumab after surgery? Is there a need for that? The NCCN guidelines suggest that we should consider that. And really, I think nothing bears more importance to patient-centered care than when you are treating a patient in the preoperative setting, where the medical oncologist does one thing, the surgeon does the next thing, the radiation oncologist does the next thing. So it really does require a true multidisciplinary approach. But even with all of these studies, there have really been no formal guidelines regarding what should we absolutely need to do. I think the take-home message is basically really make certain you know where you're starting with the size of the tumor, and then assess halfway through therapy, and then sometimes even before surgery, just so there's no surprises. We also can assess response after treatment, and we've talked a lot about a complete pathologic response. And how we correlate a complete pathologic response, which is basically the absence of tumor in the breast at the time of surgery. We look at tumor sizes. There's all kinds of other criteria, residual cancer burden, that really tries to take into account great responses where there's still cancer left. But at the end of the day, the path report is really kind of your gold standard for how well the treatment worked. All right, well, we've had a kind of a long journey, but an exciting journey through the use of HER2-targeted therapies in the preoperative setting. We've demonstrated that Pertuzumab in the neoadjuvant setting improves pathologic complete response, and at least in the neoadjuvant setting, improve long-term outcomes such as event-free survival and overall survival, as was witnessed in the Neosphere study. We know that Lapatinib led to an improvement in complete pathologic response rate when added to Trastuzumab in the preoperative setting. That's the NeoALTTO study. But the ALTTO study failed to confirm the benefits of adding Lapatinib. And I'm hoping that with all of the data that we've gone through today, you have a kind of a good sense of really the breadth of data that would support the use of neoadjuvant therapy for women facing HER2-positive breast cancer.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/QSA. This CME activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. This activity is supported by an educational grant from Genentech.